It's 8. We should start now.
So good evening, everybody. Welcome to Sandhya Pathshala of WAP, the brainchild of our President, Professor Kalpana Datta. So today our discussion will be on neonatology. So I'll request Professor Datta to welcome all the experts and the presenters and the audience in this Sandhya Pathshala. Over to you.
A very good evening to all. And thank you, Dr. Shapun, our scientific chairperson and President-elect 2024. Congratulations for being President-elect in 2024, Dr. Shapun Roy. And I welcome all the experts, Dr. Ratan Kumar Vishwas, Dr. Dinesh Munia, and today's mentors are Dr. Meenakshi Bhaumik and Dr. Habibul Awan. And the presenters are my own students. Lugna was my past student, and Agrani Panda is a second year resident. And Habib is also our student. Now he's doing the, I think he's an SR, no? In SSK? Okay. So we are running this Sandhya Pathshala every month, the last Sunday from 8 to 10 p.m. The purpose of this Sandhya Pathshala is to empower the postgraduates about the case presentations and to face the vivas, because all the senior teachers and who are going to be your examiners, they'll be discussing your cases, so it will be easy while you're dealing with the cases during your exam. So we, for the last from the January to September, we are doing every month different subjects like case of nephrology, neurology, gastroenterology, pulmonology, hematology, lots of cases we have done. Now, today we'll be discussing on a case of neonatology. So I'll request the experts, please be specific to the clinical oriented cases, not too much theoretical discussions, but it will be better if you discuss the clinical oriented so that the postgraduates will be, acquainted with the cases and can deal with the cases while doing the clinical duties. So now I request Dr. Meenakshi Bhaumik to, first I will request introduce Dr. Dinesh Munia, today's expert on a case of neonatology from Associate Professor in charge of Neonatology of Medical College, Kolkata. Welcome Dr. Dinesh in this platform. Now I request, I'll welcome Dr. Meenakshi as a mentor and SR in our department, and you introduce the Agrani, and then if you want to say a few words, and Agrani will start presenting. And welcome Dr. Atanu. Okay, so Dr. Meenakshi, just introduce Agrani and ask her to present the presentations.
Thank you, ma'am. A very good evening to everyone. Thank you for joining us on this digital platform for today's Sandhya Pathshala. We have our first speaker today, Dr. Agrani Panda. She is a second-year postgraduate resident in Department of Pediatrics and Neonatology, Medical College, Kolkata. She'll be presenting few interesting cases pertaining to a very frequently encountered scenario in day-to-day neonatology practice. So without further ado, let's get to the presentation. Over to you, Dr. Agrani. Please start with your presentation.
Thank you, Dr. Meenakshi Di, and good evening, everyone. I am Dr. Agrani Panda, Junior Resident, second year in Department of Pediatrics, Medical College, Kolkata, and thank you for this opportunity. So today we are going to discuss a few cases on a very frequently encountered disease or condition, rather condition in our NICU unit, that is persistent pulmonary hypertension in neonates.
Share your screen.
Yes. So what we call a persistent pulmonary hypertension, it essentially means there is a failure of transition from fetal to neonatal circulation after birth. That is, after birth, with the first breath, the pulmonary vascular resistance falls, and with the umbilical cord clamping, the systemic vascular resistance rises to establish a neonatal circulation. Now, when there is failure of this process due to any cause, it called as persistent pulmonary hypertension. So it can be of idiopathic origin, it can be of various secondary etiologies, and it essentially reflects as an unresponsive hypoxic respiratory failure situation. The incidence of this condition is 0.4 to 6 per 1,000 live birth as per recent studies. Now, we have 3 cases to discuss today. The first case, it is a 38-week-old term baby of 2.76 kg, which is delivered by normal vaginal delivery. There was no certain antenatal risk factor, but the baby did not cry at birth and required resuscitation of back mask ventilation more than 1 minute. So we considered it as a severe perinatal asphyxia. The baby was intubated, shifted to NICU and put on ventilator on the day 1. After that, the patient was hemodynamically stable for the day and saturation was maintained. We did a sepsis screen and it was negative. Now, on the second day, after 24 hours, we have received repeated desaturation of the baby, and the desaturation episodes essentially increases while the nurses were handling the baby. There was tachypnea, the respiratory rate was about 78 per minute, and there was subsequent retractions as well. So we optimized the ventilator settings. We have tried and upgraded the ventilator settings as much as we could. And still there was a saturation difference in the preductal and the postductal area of the baby, which is about 12 to 14% difference. So we have considered it as a case of probably pulmonary hypertension, persistent pulmonary hypertension, and we started milrinone infusion at a 0.5 microgram per kg per minute dose after giving the bolus dose. You can see the ABG. There is retention of PCO2 and pH is showing a respiratory acidosis pattern, and PO2 is significantly low. Now we did an X-ray, and the X-ray showed certain hyperinflated lung with a increased blackening in the lung parenchyma. Now, on the next 12 hours, we have seen the patient developed poor pulse volume, the CRT was prolonged. So we had to start infusion noradrenaline as an inotrope as per the recommended dose, and we added the first line antibiotics. But after 48 hours, the saturation was of 70 to 75% in the preductal area. So we had to increase the milrinone infusion. Next step, in the next step, we started sildenafil infusion as well, giving the loading and maintenance dose because there was no certain improvement. And we continued it for the 48 hours. We did an echo on the baby. There was no certain structural heart disease, but there was significant tricuspid regurgitation jet present here. After starting the sildenafil and continuing it for certain time, the oxygenation improved and the saturation became 90 to 95% in that baby. On the day 4, baby developed significant hypotension. The MAP was reducing, though the saturation was maintained. So we increased the noradrenaline infusion rate. After certain time, after 12 to 24 hours, we have tapered the sildenafil infusion and omitted it over the next 12 hours, and we shifted onto oral sildenafil. Milrinone and noradrenaline infusion was also omitted over the next 48 hours. We could extubate the patient and put on CPAP, and gradually we tapered the airway support, and we could successfully discharge the baby on day 10 with oral sildenafil. This is the first case of PPHN we have dealt. Now, on the second case, here there is a 2.2 kg, 37.
Just wait.
Yeah.
Dr. Agdoni, I'll ask the experts, please discuss about the possibilities when the patient came after 20, even after 24 hours of giving oxygenation, there's a persistent desaturations and all. So what are the DDs? You have already described the treatment, but you have to have a DDs. And then you will do some investigations or the maneuvers, and then you will treat. So please request the experts to comment on that part and discuss so that the postgraduate will be benefited. Dr. Dinesh? Dr. Dinesh or Dr. Ratan, and one can take the questions and the discussion part.
Am I audible?
Yes,
Hello?
yes, audible.
Yes. Basically, there is why you are seeing that PPHN. First thing that there is repeated desaturation, and initially we think that desaturation may be due to the either pneumothorax or any other lung disease. If there is X-ray suggestive or no pneumothorax, and there is no blockage of the endotracheal tube, we think that there is persistent desaturation and there is preductal and postductal saturation is different. We think at that time there is PPHN. Baby may develop PPHN. Because of this, most of the parental aspects of baby develop PPHN, usually not immediately after birth, maybe develop after 12 hours or 24 hours after birth. And why, Ogroni, why you start the sildenafil first?
Okay. Sir, as a pulmonary vasodilator, as we have excluded almost all the disease that we will think of cyanotic heart disease or pulmonary parenchymal disease in this patient, but we have done an echo, we have done an X-ray, so we didn't find really anything. So we have thought it to be a PPHN, and we have started on milrinone, which is a pulmonary vasodilator. But even after giving milrinone, the condition was not improving. So we started sildenafil infusion, as it is a selective pulmonary vasodilator which acts through the cyclic GMP pathway. It increases the nitric oxide release. So we started the sildenafil infusion to increase the pulmonary vasodilation, to decrease the pulmonary vascular resistance, so that the saturation improves.
Whether you start sildenafil first or milrinone first? In which situation you start sildenafil first?
Yeah. So okay. In our settings, in cases of PPHN, the studies have showed the first drug and the magic drug used to be inhaled nitric oxide, but we don't have that in our settings. So whether to start milrinone first or sildenafil first, generally we decide it depending on the hemodynamic status of the baby. We see if the baby is hemodynamically stable, the MAP is maintained, the circulation is okay, we can start with the sildenafil at the very first point. But if the circulation is poor and the patient is hemodynamically unstable, we are suspecting a little of LV dysfunction, then milrinone will be a better choice to start with, because it has a positive inotropic and lucitropic action as well.
Basically, we start milrinone when there is pulmonary venous pressure is high. When there is pulmonary venous pressure is high, means that there is TRZ is there, tricuspid regurgitation is there. That means suggestive of the PPHN, pulmonary hypertension. But till there is left to right shunting at PFO level and both bidirectional shunting at PDA level. At that time, we can start milrinone first. And sometimes if there is baby having hypotension and hemodynamically unstable, we start sildenafil first. If we think that this blood pressure is normal and there is no gross hypotension is there, so we can start at that time. You can start the sildenafil. Okay, you continue.
Can I ask a question?
Yes, sir.
Yes.
When did you do the echo?
We did the echo on the first time, just after 4 to 6 hours, when we got the repeated desaturation episodes, and we have tried increase the ventilator settings, and still the baby was not maintaining saturation.
You did echo on 4 to 6 hours, and what was the findings?
4 to 6 hours when there was repeated desaturation, sir, and we did not find any structural heart disease like VSD or any left ventricular outflow obstruction or any TAPVC kind of features.
You said
and
that
we
regurgitation rate.
Regurgitation, we got a tricuspid regurgitation rate.
How you calculate these things? PPHN,
you didn't say anything about your baby's oxygen saturation index or oxygenation index.
Can I request both the experts, please increase your volume?
Probably it's high enough. Okay. You didn't say anything about intraatrial shunt. Okay. You didn't say anything about ductal shunt. You just told one thing, that the baby was having a tricuspid regurgitation. Can't we have a baby with right ventricular dysfunction having tricuspid regurgitation without any pulmonary hypertension?
Yes, sir, we can have that kind of situation, but clinically also we are having a very labile oxygen saturation, and there was desaturation with repeated handling, which generally we find in PPHN.
Okay, I am giving you a scenario. Say your baby
Okay.
is suffering from asphyxia, bound to have some ventricular dysfunction, and transition is a bit compromised. So we can have a pulmonary, temporarily pulmonary hypertension with a dysfunctional right ventricle. In which case, we'll get a bit right to left shunt to duct and also a bit pulmonary regurgitation. Will you call it a PPHN?
So if there is, it can be a transient pulmonary hypertension. It can be when the pulmonary pressure is not very high. As you said, we can go through the oxygenation index and calculate the pulmonary pressure by the TRJ, tricuspid regurgitation severity, calculating that. The case you given the scenario, it can be a transient hypertension as well due to the asphyxia.
And you did start milrinone. Okay.
Yes.
How did you stabilize your patient first before starting milrinone? You haven't mentioned.
Sir, before starting milrinone, we have checked the patient was circulation was okay. Patient was hemodynamically stable, like the CRT and the pulse volume was good, and then we started milrinone after giving boluses.
You just told that optimize the mechanical ventilations and you rule
Yes.
out the other things, and then you start the milrinone. After optimization, the mechanical ventilation and all. Sedation, optimization of the mechanical ventilation.
Okay, continue.
Okay. In the next case, sir, we have gotten a 37-week-old 2.2 kg baby delivered by cesarean section due to severe oligohydramnios, and the baby cried after birth. Now we have put the baby in SNCU. Now after 12 hours, baby developed severe respiratory distress with tachypnea and grunting. So we had to shift the baby to NICU. We put the baby on CPAP with this setting, a PEEP of 5 and FiO2 of 40%. And then we stabilized the baby initially. Now, after day 1, the baby developed cyanosis and there was persistent desaturation. Again, the distress was increasing, baby going into CPAP failure kind of scenario. And the pre-postductal saturation was again of 12 to 14%. We did the sepsis screen on the day 2 and it was negative. So we first put the baby on NIB and on optimum settings. Still there was saturation was poor and there was poor pulse volume as well. So we started first with the inotropes, that is infusion dopamine and dobutamine. We give the first line antibiotics, and then there was still labile oxygen saturation and hypoxemia. So we have started, thought that of maybe of a cyanotic heart disease, as there was cyanosis. It could be a case of pulmonary hypertension as well. So we have done an echo on the next day, considering it can be a cyanotic heart disease as well. But we really couldn't figure out the echo if there was a structural heart disease or not. It was very inconclusive. We got a tricuspid regurgitation jet as well, but we could not figure out the shunting properly, how much shunting was there, and there was certain grade of LV dysfunction as well. So we started the baby on infusion milrinone and noradrenaline. And as the supportive management of PPHN, we have started the sedation as well. But the baby was not improving. The saturation was not really improving. So we have maximized the inotropes because the hemodynamic condition was not also good. And then we started infusion sildenafil. Now, still there was no improvement, and we thought we have missed a diagnosis of any structural heart disease. We may have missed. So we have started infusion alprostadil at the 0.05 microgram per kg per minute dose, and the saturation was improved to a certain level of around 90% after starting the alprostadil. Now, we have done and repeat echo with when on the next day with the experts, and we ruled out the structural heart disease. There was not really a structural heart disease, but there was flow through the open ductus, and there was right to left flow through the ductus arteriosus, and there was tear jet as well. So as we have ruled out the structural heart disease, we tried to taper the alprostyrene infusion. But whenever we are trying to taper the alprostyrene infusion, there was desaturation and there was worsening of symptoms. So we thought that there may be a heart disease we are missing. So we again maintained the alprostyrene in the same dose. The saturation was improved, and we had to continue the infusion. And over the next 3-4 days, we have tried 4 to 5 times to taper the alprostyrene infusion, and we could not really taper infusion. Whenever we are tapering, there was desaturation. So after in another 2 days, the ventilator settings, we could reduce the ventilator settings. We reduced to 40% FiO2 almost over the next 48 hours. And then with the alprostyrene infusion ongoing, we could extubate the baby and put on CPAP support. So in the next 2 days, the baby's saturation was far more improved, respiratory distress was pretty much decreased, and we could shift the baby to nasal prong, and we have tapered the alprostyrene infusion after the baby is stable on nasal prong, and gradually we omitted it very gradually, and we could discharge the baby after 7 days of giving alprostyrene. Now here, actually, we were thinking that there was certain heart disease we are missing. But with the alprostyrene infusion, though there was no heart disease, there was a certain improvement of the condition. So what we got from this case is, there maybe the alprostyrene is keeping the ductus open. So maybe the baby was having a right ventricular failure or severe dysfunction. And when there is a right ventricular dysfunction, maybe the alprostyrene infusion causing the PDA opening act as a pop-up valve mechanism to release some of the RV pressure. So maybe that act on that way. So in this case, we've seen that alprostyrene improved the baby with a PPHN condition. Sir, any comments?
Dinesh.
No. Here there is alprostyrene is started because of dilemma is that initially pulmonary vasodilator not work, and our resident think that there probably diagnosis was missed out, so they have started the alprostyrene. But alprostyrene have two function. When alprostyrene given, there is suprasystemic pulmonary pressure. At that time, the alprostyrene was act as a pop-up mechanism to forward flow from the PDA, and also alprostyrene also decrease the pulmonary dilate the pulmonary vessels, vasculature. That is why this alprostyrene is work here. But another 2 to 3 cases, there is alprostyrene not work. Because of this, alprostyrene also causing the more hypotension and apnea and all the things. So complications, all the complications, other pulmonary vasodilators. Basically, luckily we discharge this baby, and this alprostyrene do the magic. Because of this in this cases, there is shunting also is there from the right to left from the PFO.
Agrani, can I see the first slide where you started?
Yes.
Why we are having differential saturation?
Yes, sir.
First slide, please. You are having differential saturation from the very from day 2 only, no?
Yes, sir.
Why didn't you think of PPHN right here?
Sir, as we got the saturation from day 2, we actually thought of heart disease first, of structural heart disease and opening of PDA kind of thing, and that's why we started alprostyrene actually. But
No,
when we
I'm not asking about alprostyrene.
Okay.
What did you do when you see the baby is having differential saturation on day 2?
Okay, so first thing is as the preductal saturation was pretty low, so we put the baby on ventilator and optimize the settings. But
Mhm.
after that, we did an echo on the first day because there was a difference pre and postductal saturation.
Mhm.
Thinking of could be a heart disease after stabilizing the baby on ventilator and putting on optimum settings, and we really could not figure out the echo if there is an heart disease. So that's why we have thought that we missed a diagnosis. We have missed something on echo.
No, you were having a differential saturation of around 12 to 14% on the second day
Yes,
on.
sir. Yep.
So once you have you couldn't say like you couldn't exclude structural heart disease, okay? But before but seeing a differential saturation of like this amount of 12 to 14%, why didn't you think about PPHN from the very beginning? What made you stop thinking about PPHN in this case?
No, sir, we thought about PPHN. First, we thought about PPHN, and that's why we started Milrinone first. Because there was a labile oxygen
No,
situation
before
and
that
there was
you were before that you were on some other inotrope, I think.
because of this from day
sir, this
1 minute. Because of from day 2 there is a PDA is closing that causing also desaturation. We think that the residents think that day 2 there is desaturation maybe closing of the due to the closing of the PDA. That is why they are start the alpha.
I am not
sir,
asking about
here
alpha actually.
No, sir. I understood the question. We have started this inotrope because the patient was not hemodynamically stable. We were getting a poor circulation. That's why we started on this inotrope first.
Okay. Then when did the baby was stable?
The baby was stable after giving the inotropes. There was circulation was improved, but the baby was still having a labile oxygen saturation. So then we started Milrinone, and still there was no improvement. So we maximized the inotropes. We have given as we think of PPHN. We have started sildenafil as well, but still the saturation was not maintained. So then after starting alprostadil, after 12 hours of alprostadil infusion, the baby was starting to improve and having a really good saturation. Then we thought it could be a heart disease we missed.
What was the dose of milrinone in this particular case?
So we started at 0.5 microgram per kg per minute, and still we have to increase till 1.
And then you started not at.
And so we started sildenafil because we thought that we are dealing with a severe PPHN case, as we couldn't figure out the echo. But instead of even after giving sildenafil, the baby was not really improving. So then we thought that the desaturation started on day 2, it may be due to a PTA closure. So we started on alprostadil.
You started alprostadil only thinking about that the PDA may be closing and the baby is having some cyanotic heart disease.
Yes, sir.
There are 2 more questions and question answers. Anyone can take that questions.
Okay.
So there's a question: is what is pulmonary arterial pressure? So as by the echo, we calculate the pulmonary arterial pressure by the tear jet and by the right atrial pressure, tear jet and the right atrial pressure together. So we calculate the tear jet by the tear velocity, and we get an idea about the right atrial pressure by the IVC collapsibility. So summarizing that too, we calculate the pulmonary arterial pressure to determine the severity of the pulmonary hypertension. And
now she was probably the question was asking what was the level of the pulmonary pressure, and practically you never ever mentioned what is the pulmonary pressure or what is the other type of shunts. There's some problem, if you mention you were presenting a case of PPHN, you'll have to say about
Okay.
shunt through the shunt through atrial level. Then you come to pulmonary atrial regurgitation, or and you will also have
There
to
is TR gradient is 32.
care grade pressure gradient 32, not much, and the baby was not improving with so much renal nodal. Probably pulmonary pressure was not very high. 32 is not that high, na?
No, no,
Actually,
this is
that-
32 plus we will add the right atrial pressure around 10, 8 to 10.
38, still
No,
moderate.
no,
Still,
not
it falls into criteria of yes, sir.
Still moderate.
Still
this is
moderate
40, this is 40.
And
Moderate.
you were not mentioning anywhere about your oxidation index.
This-
The severity of PPHN is not being mentioned anywhere.
Okay.
Dinesh, this part should be.
There is one question in the first, I think the first case, why baby was discharged on sildenafil if the pressure were still high, and repeat it.
The sildenafil.
Then see the question answer, and there's a one question more.
Sildenafil.
Anyone can take the answer.
First, dear Dinesh, you tell me what I don't know. When did you discharge the baby?
If there's no more questions.
If in our setting we only discharge the baby after its pulmonary pressure is resolved actually.
Okay.
And discharging a baby with sildenafil, on which day the baby was discharged?
So day 12, on day 12.
Still pulmonary. What was the pulmonary pressure then?
So on the repeat echo, the pulmonary pressure was normal. When we discharged
So
the
why
baby.
did you give sildenafil in that case then?
Sir, because we thought that tapering sildenafil, stopping sildenafil may cause a rebound hypertension, and oral sildenafil has been studied to be effective as well. That's why we thought to discharge the patient with oral sildenafil, and we told the baby to come for follow up to the parents.
স্যার এই মেরিন খা তো গ্যাস দিতে লাগে কি না লাগবে না গ্যাস কিনে আচ্ছা ইনসলভেন্টটা খাচ্ছিল ওটা কি খাও না কোনটা ইনসলভেন্ট বলে একটা সিরাপ না না এটা খাও এটা বন্ধ তাহলে গ্যাস দিতে লাগবে না
Please mute all except the speaker.
So you are de-escalating sildenafil before discharge, right?
Yes.
Okay. Then the answer should be that we are de-escalating sildenafil and discharge the baby. But while mentioning any case of PPHN, always mention these three things like ductal shunt through PFO or intraarterial septum. Mention this one.
Okay.
Otherwise, the very case of PPHN becomes questionable.
Okay. Okay, sir.
Okay. The third
There
case.
are lots of learning points. Yeah, you can proceed the further cases.
Can I ask a doubt here that we thought that was doubtful, that we have given alprostadil in one case and we saw improvement, but we have also seen deterioration with alprostadil, that the BP was falling, this kind of situation. So as per the studies we have gone through during giving alprostadil, there was always a mainly notation for giving inhalational alprostadil. So there is not many study about IV alprostadil acting in the PPHN, or if it should be given or not. So should we give that when we are dealing with severe PPHN, should we give that?
Whenever your right heart is under pressure, you should offload the right heart first.
Okay.
Giving alprostadil in this particular case was not erroneous actually. You had to offload your right heart.
Okay.
And with a dysfunctional right heart, the problem will increase actually. Pulmonary bed will not give sufficient blood, and you can't expect to have a proper saturation with dysfunctional right heart. So offload right heart, and there was no problem. There was no error actually.
And so, do we have a province of inhalational alprostadil in our settings in our state or
No.
country?
Inhalation alprostadil not
prohibitively costly actually. Cost is exorbitant. Otherwise, you can easily give. There's no problem.
Okay.
Except the cost.
Thank you.
Oh.
Proceed for the next case. Okay.
In the third case, we are dealing with a late preterm 35-week-old girl baby of 1.8 kg, which delivered through cesarean section due to PPROM and fetal distress. There was a severe perinatal asphyxia. Baby did not cry at birth. We needed bag mask ventilation for more than 1 minute, and the baby was put on ventilator on day 1. So this was the initial chest X-ray of the baby, and this was the initial VBG finding of the baby. We see metabolic acidosis as well. So in this baby,
X-ray was not properly visible in the screen.
Sir, it is probably due to some problem with the exposure.
No, the
Visible?
images of panelists and the participants are being imposed on that.
So put up the videos. Put up the video.
Okay, proceed. pH was 7. I can see. PCO2 was 38. I couldn't see. I am being able to see only the right part of the chest and nothing. Okay, chill.
So we put the baby on ventilator on minimal settings, and initially we stabilized the baby. In this case as well, we got a very labile oxygen saturation. There was repeated desaturation on the day 2. So first thing, we were optimized the ventilator settings, and as we with many cases, so we have started with milrinone, thinking it could be we are dealing with a case of PPHN, as there was a severe birth asphyxia and a sedation as usual. So there was not really any improvement. And on the day 3, we did a sepsis screen as the baby was deteriorating, and we got a positive sepsis screen. So we added antibiotics, we started on inotropes, and we optimized the milrinone dose. Now, in the next day, we did an echo, and we got severe tricuspid regurgitation jet. As you can see, it's almost 54.5 of tricuspid regurgitation jet pressure. So we started the inotrope, maximized the inotrope dose, and we started on sildenafil as well. Now, on the day 4, we got the blood culture positive, but we didn't get the subculture on the day 4. So we actually upgraded the antibiotic as the condition was not improving, and we started alprostadil as well in this case, thinking that we could have, on the previous case, on our previous case scenario, we have gotten better result with alprostadil. When the baby was not even improving with sildenafil, we started alprostadil because there was a severe right ventricular dysfunction as well. But again, there was no improvement. So in the next step, we given steroids. We have given steroid. Still, after giving 4 doses of steroid, there was no significant improvement. The hypoxemia persistent, and the baby went into refractory shock, and actually we lost the baby. We couldn't revive the baby after day 5. And this was the repeat chest X-ray where we have seen some developing patches over here. So we thought there was probably certain development of PPHN due to the birth asphyxia, and it probably deteriorated because the baby developed a pneumonia and went into resistant shock. So we have given steroid in that case, and still there was refractory shock and we lost the baby. So from this case, we have gotten into thinking that should we use steroid when we are dealing with a resistant case of PPHN? Because as we have seen in studies, there are steroids can be used and it has a certain action on rehabilitating the pulmonary vasculature. But when we are giving with an infection, should we actually use steroid? This was our dilemma to here in this case. So can you please let us know whether we should use steroid or not in cases like this?
Steroid is last thing that I will actually give in any case, be it hypotension or be it something else, particularly if a baby is having already infection. Not all cases are actually recoverable with the medicines that we have.
So we have almost 4 to 30% of mortality in PPHN cases, and we have seen cases going into refractory PPHN and leading to refractory shock and couldn't revive the baby. So we have gone through some studies and we have got that steroids are they actually increases the endogenous nitric oxide release as well and reduces some oxidative stress and modulate the pulmonary vasculature. But given when there is an infection scenario, but a patient is going into refractory shock, should we use use steroids?
Actually, steroid in the cases, if you think that sepsis is most important thing, don't give this. And if there is, suppose a baby develop PPHN after aspiration pneumonia, then you can think that there is inflammatory condition is suspected, so we can give, or either mass also there is some kind of inflammation you can give also. But if there is, if you are strongly suspect that culture positive sepsis, may not act for that.
Dr. Alok Pal has asked inflammatory markers. Did you go for the inflammatory markers investigations?
Basically,
Madam,
we are going to this.
we have gone through sepsis screening. Sepsis screening for the baby involved one inflammatory CRP that was negative in the first 2 cases, but positive in this case.
Okay.
No,
Dr. Dinesh, continue, please.
Okay. Basically, nowadays we have only 3-4 drugs for the permutation combination for the management of the PPHN because of the non-availability of this inhaled nitric oxide. Though we think that the inhaled nitric oxide is best drug to control this PPHN, but we don't have this at that time now. We think that if there is baby is develop PPHN and baby having hemodynamic stable and there is mild to moderate to severe PPHN, and we start this sildenafil fast. If you think that there is ventricular dysfunctions, means due to the baby develop the PPHN after parental asphyxia or sepsis, they have some ventricular dysfunction. At that time, Millinone is the best choice to start the Millinone first, and most of the cases maybe we add second drugs, third drugs, means causing the inotropic effect, and also control the blood pressure, and also some amount of pulmonary pressure. That is why we usually give the noradrenaline along with the sildenafil or And last drug, what you told that alposterol usually not improve too much cases, only few cases alposterol improve, but alposterol is, if you are availability of the inhaled alposterol, this is best.
Actually, what can be done here, baby with say in this gestational age? Titrating the inotropes are also very important actually.
Yes.
If you go through NHS guideline, you'll see that without not going, they're not going by 0.5 millino directly. In case of preterms, they titrate the dose like starting 0.15 microgram and then going upwards, like in between they're doing echo and getting the actual pulmonary pressure level like. And because the problem is with this amylinone that if it causes hypotension, it will persist for 4 to 6 hours actually, which may lead in refractory shock in your baby actually. And also we are using NODAD, which may cause renal failure, or in a case of dysfunctional heart may pose more problem for the heart. So titrating NODAD dose is 0.1 sorry, 1 microgram per kg per minute should be, and then we should go upwards like after every 15 minutes. In case of millinone, plus your pulmonary pressure, then you can go upwards by increasing every 2 or 4 hours. This is a step that can be taken to titrate the inotropes that we have, but particularly all the medicines cannot subdue all the babies actually. If it was so, I know it would be out of repute. So for this particular case, I don't know, I haven't seen, but refractory shock may be a problem with, say, septic shock and already asphyxiated baby. Maybe we could, there was nothing to do with this baby actually without INR like that.
So I want to know that do we have any province of inhaled nitric oxide in any hospital or institution in India who are using nitric oxide?
We are using nitric oxide in our institute.
Okay.
Many centers have iron.
We use it.
Okay. And sir, the guideline says that if we are using inhaled nitric oxide, we should have an ECMO facility or an affiliated ECMO facility where we can shift the.
No,
is it really needed?
No, there's some problem in your case. You see, in these 3 cases, it was never mentioned what was the actual pulmonary pressure level of the baby. What was the other shunts except TRJ. So it's very hard to comment on the baby's deterioration or progression of disease. Second, we don't have any ECMO in our setup, but we use high frequency. We use INO and plain PPHN. Sulagna will say more, but death rate from PPHN is not that high in our setting actually. But definitely there must be some problem with medicines only.
So I think now we can go for the last case. 11 minutes more to go for you. Okay.
Rest of my portion is mostly the theories of PPHN. So we are summarizing all 3 cases where in the first case, we actually managed the baby with pulmonary vasodilators. And the second case, we thought it to be a misdiagnosis. We started alprostadil to load off the right ventricular dysfunction and we got an improvement. And on the third case, we could not save the baby. It went into refractory PPHN and refractory septic shock as well. So next part of my slide is mostly on theories of PPHN, how the circulation develops from a fetal circulation to neonatal circulation, pulmonary vascular resistance falls, and pulmonary blood flow increases. With the umbilical cord clamping, the placental circulation is eliminated and the systemic vascular resistance increases. And when we are not getting this process smoothly, not getting this transition smoothly due to any cause, we are getting a PPHN case scenario. And there can be a definite etiological and risk factors for PPHN. There can be idiopathic PPHN, that is when the pulmonary vasculature is or maldeveloped due to time of in utero fetal stress or hypoxia, maybe a severe oligonucleosis or PROM or absent fetal movements kind of thing, or if there is a maternal drug intake of NSAIDs or SSRI that caused premature ductal closure, or secondary PPHN that can be secondary to a parenchymal lung disease like MAS or RDS or pneumonia, or due to lung hypoplasia, CDH. In cases of CDH, we don't really see very much improvement with sildenafil also, because there is lung hypoplasia, there is not much of lung vasculature to increase the flow with. So when we generally suspect a case of PPHN when there is any kind of suggestive history and there is labile oxygen saturation, there is a certain pre and post ductal oxygen saturation difference, tachypnea, respiratory distress, and marked hypoxemia. And in these cases also, we have to thought about cyanotic heart disease as well and rule that out through an echo. So in the investigation, we generally do an ABG or VBG, and we get hypoxemia, pre-post ductal difference of PO2 as well. And we have not mentioned oxygenation index in our cases. That was a mistake. So oxygenation index actually was important for grading the severity of PPHN. So in most of the idiopathic cases, we get a black lung PPHN, where there is increased blackening of the pulmonary parenchyma, and we do a chest X-ray generally to rule out other causes as well, like if there is an CDH or pneumonia, etc. According to the oxygenation index grading, it's a mild PPHN if we are getting an Y of less than 15, moderate if 15 to 25, and severe if more than 25. Now, we should do echo in all cases of PPHN where we are suspecting, because to rule out a structural heart disease, to go through the shunting through PDA or PFO, and to get the idea about the ventricular function as well, to assess the pulmonary pressure by the tricuspid regurgitation rate and the RF pressure, and if there is increased LV or RV dysfunction, that we can see through the shifting of IB septum as well. So there's supportive care is very important in cases of PPHN. We need to maintain the temperature. We need to avoid stress. Generally, we patch the eyes and ears and try to minimize the sound and everything in ICU. And we have to give enough fluid and inotrope to maintain the intravascular volume as well. We give sedation to prevent the agitation that can increase the pulmonary vascular resistance as well, and try to maintain an oxygenation of 93 to 97% as per the recent guideline. And actually giving oxygen is the preliminary for cases of mild PPHN, is the best pulmonary vasodilator. So it should be given as the first point of care. And generally in the ventilator, we try to give an optimal PEEP, adequate FiO2, and we try to balance our relative permissive hypercapnia, avoid hyperventilation because that can compromise cerebral blood flow as well. And actually in cases of parenchymal lung disease like MAS or RDS, studies have shown that HFOB actually give a better lung recruitment and better result, but we do not have a setup of HFOB in our NICU unit, so we give in PRVC mode on optimum ventilator settings. And we try to achieve an adequate lung recruitment and maintain the FRC as much as possible. And these are the certain drugs that we have in hand when we don't have inhaled nitric oxide, that is milrinone, sildenafil, certain prostacyclines, prostaglandin analog alprostadil, and endothelin antagonist, that is bosentan. And the last resort is ECMO, but it is not available in our settings. And also, as I mentioned, inotropes are very important. Generally, we can give dobutamine, which increases the myocardial contractility and systemic vascular resistance as well. But we do not really use this when there is a severe ventricular dysfunction, and because the dobutamine increases heart rate, so it will ultimately increase the myocardial O2 consumption. Noradrenaline we prefer as inotrope because it increases the systemic vascular resistance disproportionate to the pulmonary resistance, and also it have certain stimulatory action on endogenous nitric oxide release as well. Inhaled nitric oxide, this is the mechanism of inhaled nitric oxide and the starting dose, and it can be act an idiopathic and secondary PPHN in both of the cases. But studies have shown that it is not really effective in case of congenital diaphragmatic hernia when PPHN is associated with this case. As we have not practically dealt with inhaled nitric oxide, we don't have first-hand experiences. So I want to know, sir, is there any improvement with inhaled nitric oxide when we are dealing cases of PPHN with CDH?
Actually, no.
Yes.
In CDH, there is a change in vascular muscle layer also, and it doesn't increase dilate with INO actually. So in CDH, you will get no improvement with INO.
Okay. Now, the drug we mostly use, we have mostly 3 drugs we use in combination. One is milrinone, one sildenafil, and alprostadil. Milrinone is a better choice when there is a left ventricular dysfunction because it has a lusitropic action as well. And when there is hemodynamically instability, we start at milrinone first. If the baby is stable, we can start at sildenafil first as well. They have all of them mostly have the side effect of causing certain amount of systemic vasodilatation and hypotension as well. There is a mechanism of sildenafil and studies that showed sildenafil causes some improvement. And also we have seen in studies that using sildenafil with inhaled nitric oxide actually prevent rebound pulmonary hypertension when we are tapering the inhaled nitric oxide. So I want to know something about that too also, sir, because we don't have this first-hand experience. Do we use sildenafil with inhaled nitric oxide as well? Because that will cause too much vasodilation.
Dr. Abduni, you have to wind up. 3 minutes more.
Okay.
If it is needed, you can actually give. There is no problem. But
okay. And so there are some prostanoids which actually works through the cyclic AMP pathway, also increases the nitric oxide. There is certain evidence in other countries of using ipoprostanol, iloprost, or treprostinil, which we don't have really in our settings, which are prostacyclins. And next, we have talked about alprostadil, which act as a pop-up valve mechanism when there is right ventricular dysfunction. And there is another thing, endothelin receptor antagonist, bosentan. It has been used in studies for older childs for pulmonary hypertension of different etiologies, but not really used in neonates in any studies. And we have talked about steroids, whether we should give it or not. It generally given as a last resort, but its use is in dilemma when we are treating with a case of infection as well. Early surfactant therapy in term babies with PPHN have shown to reduce the risk of mortality and reduce the need for ECMO when we are dealing with a parenchymal lung disease. So these are take-home messages that PPHN, it can be of various etiology, severity, and outcome. It can have a very high mortality rate as well. We don't have inhaled nitric oxide, which act as a wonder drug for PPHN. So we actually use milrinone, sildenafil, and alprostadil according to the condition of the baby. And also we have to maintain patient's hemodynamic status and cardiac function as well. Proper using of inotropes is also needed. And we can use steroid, but its use is in dilemma when we are dealing with active infection. And still, even after using all these drugs, we can lose some of the babies. So these are the references, and thank you so much. Sir, any questions?
Thank you, Dr. Agroni. The questions I request all the participants and delegates who are there, please post your questions in the chat box, and the experts and the mentors and the presenters may answer in the chat box only, because otherwise you don't have a time. So thank you, Agruni, and the experts have done a wonderful discussion. Agruni has presented very nicely and lots of discussion, and we will discuss again more and more. So now I'll request, we have Dr. Habib. He has joined. He's a senior resident in the neonatal department of postgraduate Institute of Medical Science. And I request Dr. Habib, please to introduce your presenter, and both the experts will be there and will interact with the Shulagna. So Dr. Habib, how are you?
Yes, ma'am.
Okay. So just introduce,
I'm-
okay. Introduce Shulagna and start her presentation.
Yeah, thank you, ma'am. Now, Dr. Shulagna Datto, she is a second year postdoctoral trainee at the Department of Neurology, SSKM Hospital, will present a case. The case is very common, but we commonly encounter the NICU. But often we mismanage such case or often fail to manage such case. So, without wasting much time, I will ask Shulagna to share his screen and start her presentation.
Thank you, Habibda. Good evening, my teachers, my friends and colleagues. Today I will be presenting an interesting case of neonatal fungal sepsis. As we all know that sepsis is a very common cause of mortality in India, and fungal sepsis is especially very common in preterm and extremely low birth weight babies. So today I will discuss about a 34-week-old baby. This was an outborn baby delivered by elective LUCS somewhere outside in a private hospital. It was a female child, birth weight 1170 gram, asymmetric IUGR. The baby was referred to our hospital at day of life 10. At that time, the corrected gestational age was 35 weeks and 3 days. The admission weight was 1080 gram. Now, a brief discussion about the antenatal history of the baby. The baby was born out of non-consanguineous marriage. It was a spontaneous conception. The mother was primey, 19 years old. Mother's blood group was A positive.
Share your screen, Shulagna. Please share your screen.
Just a minute, sir.
Go to slideshow now.
Is it okay?
No, it's okay now.
Yes. Yes, now. Yes.
Starting from the antenatal history again, the baby was born out of non-consanguineous marriage. It was a spontaneous conception. The mother was a primey, 19-year-old woman. Her mother's blood group was A positive. In the first trimester, there was no history of fever, rash, or any urinary complaints. No history of previous abortions. In the second trimester, there is no history of diabetes, hypertension, or hypothyroidism in the mother. In the third trimester, there is no history of any dribbling or bleeding per vagina. One significant history was that there was oligohydramnios and the amniotic fluid index was 3. Now, the baby was referred at day of life 10 from the local district hospital. The baby presented with lethargy since 5th day of life. There was one episode of abnormal body movement, yellowish discoloration of body up to palms and soles, and dark yellow urine. Now, general examination. At triage, when the baby was initially evaluated, the baby was lethargic, icteric up to palms and soles. The peripheries were cold. Overall, the baby was cachectic, dry, scaly skin was there. There were rashes all over the trunk. The umbilical site was healthy with foul-smelling discharge coming out, and there was no obvious dysmorphism. On admission, the heart rate was 124 beats per minute. Saturation was 100% in room air. Blood pressure was 66/48, which is above 58 centile. Blood sugar was 37 milligram per DL, and there was 12% cumulative weight loss in 10 days. Now, after admission, we first send the baseline investigations. The hemoglobin was 9.5 mg per dl. Hematocrit was 23%. Total count was 6,900, where ANC was 1,800. LFT was sent and total bilirubin was 23.9, but the direct fraction was 12. Alkaline phosphatase was 237. Albumin was 2.5. Total protein was 3.8. AST was 95. Among the renal parameters, urea was 22, creatinine was 0.9. One significant finding in the complete blood count was that platelet count was 47,000 and PT INR both were deranged, 22.4 P time and INR was 2.1. The initial blood gas was pH 7.38, PCO2 31.9, bicarbonate was 18.8, base excess was -11. Electrolytes were more or less in the normal range. On admission, we took blood culture and sent urine culture as well. Now on admission, in view of hypoglycemia and seizure, 10D bolus was given and GIR6 was started. The baby was initially kept in room air. Blood cultures were drawn and antibiotics were started, though our first line antibiotic is piperacillin, tazobactam and netilmicin, but as it was an outborn baby and the baby was sick, so we started the third line antibiotic from the very beginning, that was meropenem and netilmicin. And in view of thrombocytopenia and deranged coagulation profile, platelet and FFP was transfused. PICC line was done and TPN was started. Next day, we sent the second line investigations. Torch profile was sent as the baby had direct hyperbilirubinemia and it was SDA baby, so torch was sent where IgG to rubella and rubella was positive. IgG to toxoplasma, CMV and HSV were negative, but IgM to rubella, toxoplasma, CMV and HSV were all negative. So we did not get any significant finding from the torch profile as none of the IgM were positive. Urine culture showed no growth. Lumbar puncture was done. CSF showed 70% lymphocytes and 30% polymorphs. Sugar was 37 and blood sugar was 180 at that time, so it was less than 2/3. And protein in CSF was 337, quite high. CSF culture did not show any growth. So there was biochemical meningitis. Now at this point, we could have thought a few differential diagnoses. One is sepsis. The points in favor were, one is hypoglycemia, then thrombocytopenia was there, coagulopathy. It was a outborn baby, very low birth weight, and CSF was also suggestive of biochemical meningitis. So our first DD was sepsis. We also thought of congenital infections initially, but there was no significant antenatal history of fever and rash in the first trimester. Torch IgM panels were all negative. There was no hepatosplenomegaly and no microcephaly. Now, it could also be just normal complications of IUGR like thrombocytopenia, hypoglycemia, increased bilirubin. All these could be due to IUGR only. Then it can be metabolic disorders because there were hypoglycemia, coagulopathy. It could be acute hepatic failure because there were hypoglycemia, coagulopathy and cholestasis. So these were the differential diagnoses that were in our mind at this point. Now, as sepsis was our first DD, so the points in favor of sepsis were thrombocytopenia, coagulopathy. This was a very low birth weight baby, and in the peripheral hospital also the baby received various types of empirical antibiotics, and there were worsening cholestasis. So all these were in favor of fungal sepsis, but the baby had hypoglycemia, which is usually less common in fungal sepsis because in fungal sepsis we usually get hyperglycemia, but hypoglycemia can be explained by the SDA status of the baby. So fungal sepsis came to our mind at this point as the blood culture report was still pending at that time. Now, as the blood culture report arrived, the blood culture was positive for Candida. And the sensitivity pattern was amphotericin B was sensitive. And so at this point, we started amphotericin B at 1 mg per kg. After 48 hours, as the baby did not improve, the baby was still lethargic, not taking feed. So we repeated the blood culture, and the repeat blood culture again showed Candida species, but this time this was amphotericin B resistant. Now, if we recapitulate the course so far, at birth, the baby had low platelet count, 47,000, for which the baby received platelet, and the platelet gradually increased. And the renal parameters, if we see initially, the creatinine was 0.9. After the blood culture was positive for Candida, amphotericin B was started. And on day of life 14, what happened is that the blood gas showed sodium 105, creatinine after receiving amphotericin B for 48 hours, creatinine raised to 1.2. And the baby had recurrent episodes of apnea and gasping type of breathing. So, considering it as symptomatic hyponatremia, at day of life 14, that is after 4 days of admission, the baby was intubated. And as there were repeated episodes of hypoglycemia, so the glucose infusion rate was progressively increased to 12 mg per kg per minute. Now, after 48 hours, the baby was again extubated to NIV, but on day of life 17, creatinine raised to 1.5. And as we know that with amphotericin B, the target creatinine should be less than 1.5. So dose adjustment was done, and gradually the amphotericin B dose was reduced to according to the GFR, but creatinine again on repeat testing, creatinine was 1.7, and again platelet reduced to 55,000. So on day of life 20, repeat platelet transfusion was given. Now, the main problem so far was persistent candidemia, because even after 48 hours of ampho-B treatment, the repeat blood culture was Candida positive with ampho-B resistant. And if we see that, follow the trend of total leukocyte count and platelet count and the renal parameters, creatinine from day of life 24 1.9, day of life 27 2.2, and day of life 30 and day of admission 20, creatinine was 2.5. So the creatinine was gradually rising, and total count initially it was more than 6,000, but TLC was gradually decreasing, and at day of life 25, TLC was 1200 and ANC was 500. So falling trend in total counts and neutropenia was also found. Now, at this point, if we retrospect our previous management, we could see that persistent candidemia due to a few reasons. One is that there was delay in removal of PICC. All literature suggests that if we remove PICC within 24 hours of culture positive report, then there is 2 days reduction in candidemia. But what we did is that because of difficulty of IV access, we removed the PICC after 7 days of admission. That is on day of life 10, when the baby admitted, PICC line was done and TPN was started. On day 14, Candida positive report came and ampho-B was started. And on day of life 17, again when the repeat blood culture was positive for Candida, then only the PICC was removed. And at that time, second drug was added. We thought of adding flucytosine, but at that time it was not available, so indent was placed and fluconazole was started. And at day of life 20, again the second blood culture, third blood culture was also positive for Candida, and it was also ampho-B resistant. So at that time, we got flucytosine, and flucytosine was added orally along with ampho-B, and fluconazole was stopped, and the PICC tip was sent for culture, and that tip was also positive for Candida, which was ampho-B resistant. Now, if we see the timeline of antifungal medications that we administered, on day of life 10, the baby was admitted and empirically meropenem metilmycin was started. On day of life 14, Candida positive blood culture report came and antibiotics were omitted and Ampho B was started, and due to symptomatic hyponatremia, the baby was intubated. After 72 hours, the baby was extubated and Ampho B was continued, but because of the repeat culture positive for Candida with Ampho B resistance, oral flucytosine was started. On day of life 20, the baby was again re-intubated due to worsening of respiratory parameters, and this time, as we got flucytosine, Ampho B and flucytosine was started and fluconazole was omitted initially, but later on, as the third culture was also positive, so Ampho B, fluconazole and flucytosine, ultimately 3 antifungals were continued. And this was the initial chest X-ray when the baby was admitted.
Dr. Shulagna, I think you should stop here, and I would like to comment from the experts. Please comment on the clinical features, management, radiology, then discuss the differentials, then go for the further management. Thank you.
One question, Dr. Sulagna, on the admission, you said that the creatinine was 1.2. At that time, you also give the meropenem and netilmycin. Why
No,
give
sir.
the two?
Sir, on admission, the creatinine was 0.9. If you see the
This is
first
also 0.9 is also abnormal. This is 0.9 is not normal for this preterm neonates. Up to this, at that time, 0.4, 0.3 or 0.3 or 0.3 or 0.4 is normal for these preterm neonates. Creatinine is still high. Why you add this netilmycin?
actually, sir, in our unit, what we do is that after admission, if once the baby passes urine adequately, then only netilmycin was administered. So at that time, the baby was.
But I think that creatinine is high, so no needs of the giving this two drugs at a time, meropenem and also netilmycin. No needs of netilmycin.
Okay, sir.
And okay.
Okay. Shulagna,
Yes, sir.
can you hear me? So, you have shown that the baby was resistant to Ampho B, right?
Yes, sir.
Still Ampho B was continued. Reason?
Sir, in the first culture, it was Ampho B sensitive. After 48 hours, in the second culture, it was Ampho B resistant. So we did not stop Ampho B. Rather, we added the second line antifungal, and we thought to start flucytosine orally because the baby was CSF positive. So in fungal meningitis, Ampho B and flucytosine combination is recommended in most of the literatures. But as flucytosine was not available at that time, so we started with fluconazole. And then as soon as flucytosine was available, the flucytosine was added.
No, I don't have any objection in starting flucytosine. Actually, the ideal combination should have been here, flucytosine, and some other sensitive or antibiotic.
How about the caspofungin and all?
Capsofungin could be started. Capsofungin
Yes,
could be
rather than
started.
flucytosine, caspofungin would have been better.
No, flucytosine actually, ma'am, flucytosine is the only medicine where in invasive candidemia in other sites like weak kidney or brain, flucytosine will work better than capsofungin actually.
Yes,
So the
but toxicity basis.
The combination of flucytosine with another sensitive or antibiotic would have been better here. I couldn't understand twice the culture showed that either Ampho B or fluconazole or both were resistant, but you are still continuing.
And there are many questions, huh? Let's see the questions also.
Another question, there is creatinine is gradually, but you also continue this amphotericin B.
Okay, well, if you have sensitive or like if amphotericin was sensitive, it could have been continued. The dose could have been
There is a renal dose adjustment was done by calculating the EGFR.
actually by adjusting the renal parameters, you could have continued ampho. But the problem, I think, it was the comedy of errors from very beginning. Actually, the baby was clearly showing features of cutaneous candidiasis. The baby had rash. The baby had cracks or like that unhealthy umbilicus. The baby from a district hospital probably who got third generation cephalosporin like that. A broader spectrum antibiotic is a prerequisite actually for having a fungal sepsis. We could have started antifungal from the very first day. And putting a PICC is actually, as Sulagna said, that she had no other option to rather than starting putting an PICC because cannulation was extremely problematic here. But if you put a PICC, it actually going to make your condition worse. Practically, because of biofilming, you will never be able to eradicate candidemia. Number two, putting a PICC for 3 to 4 days. In any case of candida, invasive candidemia, and the after 4 to 5 days, chances of having candida in say, brain or kidney is very high. Putting a PICC aggravates that. So putting a PICC was a problem here. Shulagna, in comment?
Yes, sir. And TPN was also initially continued, so that could also be another.
You have given lipid emulsion, which could have aggravated the candida infection actually. But you had no option to also.
PICs should be removed fast because of the know that the fungal sepsis. You should remove fast for 2 to 3 days. If there is on channel is there, peripheral channel, then you can control these things.
No, she's saying that because the baby was outborn and the baby was having cachetic and other problems, putting a cannula was difficult, and that's why they started with PICC to maintain TPN or other things.
Actually, Dr. Pal has asked what is the cause of IUGR? What is the source of fungus? Is it iatrogenic?
Ma'am, from the antenatal history that we
No,
get at that
is there
time,
any history suggestive of IUGR causing IUGR?
there was no suggestive history of IUGR. Maybe, ma'am, it was idiopathic because in our country, more than 50% are idiopathic IUGR.
Okay. Dr. Shapun Roy has asked platelet count is low, so why meropenem? And it was the okay. Why meropenem is when there is a low platelet count?
Actually, sir, we started the empirical antibiotic. Later, the platelet report came, but meropenem and its association with thrombocytopenia is still debatable. Some studies say that meropenem causes thrombocytopenia. Some studies say it doesn't. So, unless there is
any comment of experts? Any comment of experts on that? Dr. Ratun or Dr. Dinesh, you can take that meropenem with the platelet relationship and cause and effect relations.
Well, with a baby who is IgA having low platelet count, meropenem can reduce actually platelet, but if it is septic, sepsis would ultimately reduce platelet. So for saving the baby, if I have to give meropenem, I can give. There's no problem. But problem is after getting so many things like renal failure, pointers to fungal sepsis. How long did you continue with meropenem?
So actually, when the first culture came and it showed Candida, ampho B was started, and at that time antibiotics were stopped.
Okay.
There's another question, causes of severe hyponatremia in this case from Dr. Sabri Ahsan.
The baby had renal failure. One cause is dilutional
Yeah.
hyponatremia can be here.
Yes.
Then any other thing? Lipido was there, which would actually cause a false hyponatremia. Triglyceride, having a high triglyceride level will falsely show its sodium level lower. And then anything other, Sulagna?
Sir, it could be nutritional as well, or meningitis itself can cause hyponatremia.
Also the baby was being ventilated. That too will lead to
sepsis itself probably would be contributory, isn't it? So, sorry, I'm Dr. Saha. I'm just watching and coming from.
Yes, Dr. Saha.
May I pitch in?
Yes,
Pitch in?
Sure.
Actually, Dr. Bivan Saha is there. So, what evidence shows?
We can take as his comments as experts.
I will take the advantage of that. Bivan has joined from Manchester. So, what evidence shows that if you just continue meropenem in spite of the low platelet count, so if something happens, so how can you justify? And in my experience in my college, I don't give, because when I stop this meropenem and we treat with the ceftazidime or any other antibiotic, the platelet count rises. So evidence-based medicine shows that thrombocytopenia is associated with meropenem. So Bivan, what is your take?
Yeah, I think it is a difficult call, Shapanda, here, because I think it is a balance between saving the baby, because sepsis, because at that point of time, a child who has come from a different hospital, and as you know, with the abundance of antibiotics that is used, and we don't really know what the spectrum would be. I mean, I would debate the combination of meropenem and netlemycin, because what would netlemycin cover that meropenem will not? Probably it covers more or less the entire spectrum. So isolated meropenem use has given some evidence of thrombocytopenia, and it is the risk. I think it is all a risk-benefit ratio at that point. If you have to save the baby, you have to just push in the highest antibiotic and save the baby, and then only you can think of thrombocyte, because thrombocytopenia straight away will not kill a baby, but sepsis probably will kill the baby in 24 hours, isn't it? So if you are not sure, and what you, I mean, this child might have had a lot of ceftazidime or whatever in the peripheral unit already. So I think per se meropenem in this case, which was stopped only after 3 days, was not a bad decision actually. I think I would probably go for piptaz or meropenem in this case. I think the trouble is where we have landed up in fungal sepsis. Antibiotics were stopped straight away, which is the right decision. I'm not sure what gestation do you follow prophylactic antifungals here in your unit, Shulagna. I'll come to that in a minute. But when a baby comes from a peripheral center, we discussed about PICC lines, and that again is another choice, whether you give more balance to nutrition first, or whether you think about fungal sepsis straight away. I think PICC line and meropenem on day one was the correct call, to be honest, because as things evolved, PICC line was removed a bit later, I know, but then again, nutrition itself has a very important role in saving these children, and sepsis itself can kill. So I think neonatology is never black and white, isn't it? Or any sort of pediatric specialty is never black and white. I think it's at that point, the best clinical decision will be variable, but I don't think meropenem it could be contributory, but it was probably not the contraindication in that case.
One question is that in a peripheral hospital, they give the third generation cephalosporin. Third generation cephalosporin we are not giving the neonatology unit, because this third generation cephalosporin usually causing the ESBL organism. So we are not to start third generation cephalosporin or ceftazidime, anything in neonatology. Otherwise, if there is culture positive and sensitive drug in third generation cephalosporin.
Okay,
Just
okay.
Shulagna, I had one question. The babies
Yes,
that
sir.
you do a long line or a pick line on, do you empirically start them on antifungals?
No, sir. In our setup, no.
Okay. Okay, that was my only question there, probably, because in some units they do it empirically. I mean, some body weight criteria is there, but a pick line itself is sometimes an indication for antifungals in some unit.
No, we don't give it routinely, sir.
Okay, okay, that's fine. Thank you.
Thank you. Ma'am, shall I proceed?
Yes, yes.
Okay. So as there was persistent candidemia, amphoby was started after first blood culture. Blood culture was taken after 48 hours, and the repeat blood culture was amphoby resistant, as I have already mentioned. So further workup for end organ dissemination was done. Now, echocardiography was done. It showed vegetations on the septal leaflet of the mitral valve, and that was confirmed by CT angio. USG KVB did not show any fungal ball. Eye examination was done. No chorioretinitis was found. In USG abdomen, no abscess in liver or spleen. USG brain was also normal. This was the echocardiography. It was done in our own echo machine of the unit. This is a fungal vegetation. CT angiography was done. It showed nodular hypodense thickening is seen along the ventricular surface of septal leaflet of mitral valve, suggestive of vegetation. This,
Dr. Shulagna, my
yes,
question is, how did you know it is a fungal vegetation? Was there any significant finding that led you to think that is a fungal vegetation?
actually, ma'am, in a baby positive with fungal infection like candida, and if there is any, initially in our setup, whenever a baby is admitted, the baby, we do a echo screen with our bedside echo machine, and at that time, we did not, on admission, we did not find any fungal ball. But after the candida positive report came, and when we did the screen, then we could see the fungal ball, but we were not very sure. So the formal cardiology referral was done, and they confirmed it to be a fungal ball, but they asked for CT angio for further confirmation. And these were the CT plates that showed vegetations, but the patient was already fungal infection positive, so it should be nothing other than fungal vegetation.
Okay, thank you. Thank you.
So far, the issues that we have discussed in this case, there was cholestasis, there was coagulopathy, hypoglycemia, thrombocytopenia, refractory candidemia, and last but not the least, fungal infective endocarditis. So from our part, if we see it retrospectively, what went wrong? First is delay in removal of PICC by 72 hours. And the organism was not getting cleared. Two repeat fungal cultures were all candida positive. There were fungal infective endocarditis proved by both echo and CT angio, and unavailability of suitable antifungal medications like flucytosine was initially not available. We had to wait for 72 hours, and we had to add fluconazole, which was intermediate sensitive only for that 72 hours. So now a brief introduction about fungal sepsis in NICU. Fungal sepsis is an important health problem in NICU. It is the cause of substantial mortality and morbidity. It is mainly caused by Candida species. The problem in specific group of babies like extremely preterm babies or babies with complex gastrointestinal disease. Now, various contributory factors are there, like PICC line or any long line for more than 7 days, TPN for more than 5 days, using intralipid for more than 7 days, using broad spectrum antibiotics, invasive ventilation for more than 5 days. All these are contributory factors to fungal sepsis, as we all know. But why to worry so much about fungal sepsis? Because even in absence of documented meningitis, neurodevelopmental impairment incidence is very high, 57% with candidemia versus 29% in non-infected ELBW babies. Similar incidence in candida meningitis as well as with candidiuria. Now, if we see the pathogenesis of fungal sepsis, there is adhesion, then colonization, then there is dissemination. And this colonization part is very important because the biofilm is consist of yeast and hyphae that is embedded in the extracellular matrix. And it forms long-lasting vegetation, and periodic detachment of septic thrombi causes dissemination into bloodstream, and that result in end organ dissemination. Like in our case, there was dissemination to heart. So, sanctuary sites for fungus, biofilm inhibits the host defense mechanism and prevent penetration of antifungal agent. Now, what was our mistake in this part is that delay in removal of central venous catheter. So, all studies have shown that central venous catheter removal lowers mortality rates, shorter duration of infection, and reduce end organ dissemination. The NICHD data shows that mortality decreased from 37% to 21% when catheters removed within 24 hours of first positive blood culture. And strongest effect was seen with Candida parapseulis, where CVC was not removed. The percentage was 31% than when it is removed. Time to clear candida from blood is on average 2 days less with prompt removal of catheter. Persistent candidemia, it depends on antifungal dosing and promptness of CVC removal. Complete clearance of bloodstream infection, median of 3 days after starting of antifungal therapy. So, from bacterial infection, this is different because it takes longer time for the blood to get cleared of candidemia. And daily blood culture of at least 1 ml. This is very important. At least 1 ml of blood volume should be drawn until 3 negative blood culture documented in first 3 days of treatment. And treatment is recommended for 14 days after bloodstream is clear of candida. So, unlike bacterial culture positive, where straightway we give 14 days of antibiotic, here after first blood culture is negative of candida, we have to give antifungal for 14 days after that. Now, incidence of persistent candidemia can range from 50 to 60 in VLBW newborns. Low birth weight was significantly associated with persistent candidemia. The lower the birth weight, the greater the susceptibility to develop persistent candidemia. And here, if we see the risk factors that contribute to persistent candidemia, prior use of broad spectrum antibiotics and presence of a central venous catheter at diagnosis, these are most important. To note, antibiotic exposure and more importantly, the choice of antibiotic and anti-aerobic spectrum of activity for routine prophylaxis and empirical antibiotic therapy was the strongest risk factor for candidemia in VLBW newborns. In this patient, there was PICC, there was high-end antibiotic use, the baby was preterm, VLBW, IUGR, all these were contributory factors. Now, non-albicans species themselves may also play a critical role in the pathogenesis of persistent candidemia due to their notorious capabilities of adherence to foreign surfaces, high virulence, and inherent or potential resistance to fluconazole. In Indian scenario, all these are risk factors for persistent candidemia, like NPM for more than 5 days, mechanical ventilation for more than 5 days, central line for more than 7 days, 20% intraliquid infusion for more than 7 days, use of more than 2 broad spectrum antibiotics, and then lastly prolonged stay in hospital for more than 28 days. And if we see the resistance pattern, in case of non-albicans candida species, amphoby resistance is very high and only 80% cases are amphoby sensitive, rest are amphoby resistant. This is one flow chart, and this shows when we should start antifungal prophylaxis. There are various guidelines regarding antifungal prophylaxis. There is one Cochrane review also. This table shows that if the baby is less than 750 grams and less than 25 weeks of gestation, and if the following risk factors are present, like central venous catheter, TPN, third or fourth generation cephalosporin, carbapenem, more than 2 days of antibiotics, complex GI disease, if any one of all these are present, and if say PICC or any kind of central line is in place, or the baby is receiving parenteral nutrition or antibiotics, then fluconazole prophylaxis should be given among 750 to 999 grams babies of 26 to 27 weeks of gestation. If one of the following risk factors are present, like third or fourth generation cephalosporins or carbapenems, complex GI disease, or 2 or more of the following, like central venous catheter or TPN, or more than 5 days of antibiotic, then also fluconazole prophylaxis should be started. And if the baby is more than 1 kg and more than 28 weeks of gestation, and if there is more than 2 days of third generation cephalosporin or complex GI disease, and the central venous line is in situ, or the baby is receiving TPN or antibiotic, then fluconazole prophylaxis should be started, 3 or 6 mg per kg IV twice weekly. Now the dose is debatable. Some studies say that 6 mg per kg fluconazole use for prophylaxis can increase resistance, and it should be given 4 to 6 weeks, or until the risk factor like the central line is present, or broad spectrum antibiotic is still being used. Until those are removed, we should continue the prophylaxis in these scenarios. Now, a few slides about fungal infective endocarditis. Fungal infective endocarditis has high mortality, and mortality rate is around 41% with Candida albicans species and 35% with non-albicans Candida species. Evidence for fungal infective endocarditis, initial antifungal combination therapy was significantly associated with better outcome when compared with monotherapy. Among various antifungal regimens used, none of them were significantly associated with better outcome. The combination therapy of amphotericin B and flucytosine compared with all other antifungal regimens showed a trend for improved outcome. So here also we considered flucytosine first to add, but as it was initially not available, so we started with fluconazole, but once it was available, we immediately started flucytosine along with ampho B. The combination of amphotericin B and flucytosine with surgery was compared with therapy without surgery in various studies, and it was observed that 77.7% of the reported cases treated with both antifungal drugs and surgery were alive, when compared with 54.3% of the neonates receiving only antifungal drugs. Ampho B alone cannot effectively penetrate and cure vegetations associated with fungal endocarditis. The addition of flucytosine or fluconazole synergistically improves the antifungal efficacy of ampho B. Combination treatment appears superior compared with monotherapy in neonatal fungal endocarditis. Among echinocandins, caspofungin represents a promising antifungal agent that is effective mainly for invasive neonatal candidemia, especially in controlling the cases refractory to conventional drugs. But unfortunately, in this case, the repeat blood culture was resistant for caspofungin, though it was sensitive for micafungin, but micafungin was not available, so we could not start that. Now, adjunctive therapies, fungal load, virulence, host factors, all these are important. And neutrophil function of the host is also important, because that is critical for candida killing and clearance, but that is physiologically deficient in low birth weight babies and preterm babies. Neutropenia should be corrected after 48 hours of antifungal therapy. In this baby, the neutrophil count was gradually decreasing. So in that case, articles show that GM-CSF or other CSF immunoglobulin therapy is not very effective in improving efficacy of treatment. So we did not go for that. There is one Cochrane I would like to mention. This was published in June 2012, Antifungal Therapy for Newborn Infants with Invasive Fungal Infection. The trial did not detect a statistically significant effect on mortality. There are insufficient data to inform practice. Large randomized control trials are required to compare antifungal drugs, drug penetrations, or drug combinations for treating newborns with invasive fungal infection. There is another Cochrane, prophylactic systemic antifungal agents to prevent mortality and morbidity in very low birth weight infants. I have already mentioned the table on antifungal prophylaxis. This Cochrane shows that there is evidence from some good quality trials that giving infants empirically antifungal drug regularly for the 4 to 6 weeks after birth reduces the number of infants who develop severe severe fungal infection. There is yet any convincing evidence that death or disability rates are affected. Now, role of probiotics. This is another controversial domain. This study, systematic review and meta-analysis, was published in Pediatrics and Neonatology in 2017, and probiotics prevent candida colonization and invasive fungal sepsis in preterm neonates. A systematic review and meta-analysis of randomized control trials. The conclusion was that limited data support that probiotic supplementation prevents invasive fungal sepsis in preterm neonates. High quality and adequately powered RCTs are warranted. So, role of probiotics is yet not recommended. Now, epidemiology, risk factors and outcomes associated with candidemia in very low birth weight infants at a tertiary South African hospital over a 7-year time period. This is recently published in this year, 2023. There is a high incidence of candidemia in the neonatal unit. Several modifiable risk factors, including improved antifungal stewardship and prevention of candidemia with oral or systemic antifungal prophylaxis, can make decrease in the incidence of candidemia associated morbidity. So, our conclusion is that neonatal fungal infective endocarditis is associated with high mortality. Unfortunately for this baby also, we could not save the baby. The baby ultimately succumbed on day 26 of life. Combined therapy is better than monotherapy. Echinocandin is promising in the treatment of fungal infective endocarditis. The lack of specific guidelines, especially regarding the therapeutic management of neonatal fungal endocarditis. Recommendations could not be easily implemented in the neonates because neonatal fungal endocarditis significantly differs from fungal endocarditis in adults or pediatric populations. So the cardiologists are also not very confident about the treatment protocol, and underlying conditions, fungal species involved, sites of cardiac involvement, treatment modalities, prognosis, outcome. There are knowledge gap regarding all this. So, take-home message is that early recognition of infection, removal of central line catheter, very important, and initiation of timely antifungal therapy. Ampho-B remains the gold standard for therapy. It is effective for meningitis as well. We have to send repeated culture daily for first 72 hours to identify persistent candidemia. We must look for end organ dissemination, prophylaxis in high-risk ELBW or selective VLBW babies, as I have already mentioned. Thank you.
Thank you, Sandhya, for your explanations and elaborate discussions. Now, I would like to have some opinion of the experts on this case, and I'd like to hear from Dr. Atanu, who is here, Dr. Vibhan Shah, and Dr. Shapun Roy. So one by one, please, Dr. Atanu.
Both of the all the cases were very interesting. The last one was, of course, raising a lot of issues. I think the answers will be helpful to all of us, and probably it would. I think in the future also we can have another session also on this topic, because it is covering almost 2 or 3 chapters of neonatology. So I think we can again concentrate on some of the chapters separately also. Thank you.
Okay, thank you, Dr. Atanu. So comments from Dr. Chopin and comments from the experts also. And I'd like to hear from mentors. Where the mentors? You want to say something? And I'll request
Yes, ma'am.
experts by the
I'm
time you
here.
answer. There is a 4 questions in the question answer. The presenters or experts and mentors can answer. So few words from the mentors first. The young.
Yes, ma'am. I
Yes,
just want to mention few points about this. Firstly, this is a case of resistant fungemia. If you see the fungal infection in NICU, it's largely by the Candida albicans group. But if you see the resistant pattern, that is mainly the non-albican groups, like Paracillosis, glabrata, and the cruzi. The second point is the end organ dissemination. In this case, there is a fungal endocarditis. So in the presence of persistent fungemia, there is higher rate for end organ dissemination. In the studies show by each day of candidemia, increase the end organ dissemination as high as 10%. And the third point is when we should use a combination of therapy in case of fungal sepsis. So in case of persistent fungemia, like more than 7 days, if there is CNS infection like meningitis or abscess, if there is disseminated infection, in that case, we should start the combination of therapy. That is the dual therapy, better than use the monotherapy. Studies show by using the polytherapy rather than monotherapy, there is a high rate for sterilization, like as high as 95 to 97%. And third is, and the fourth point is echinocandin. Only the antifungal drug is FDA approved for the neonatology use in NICU is the Ampho-B and the fluconazole. And other antifungal we commonly use in the adult ICU, that is like casofungin or micafungin, still not approved for the use in neonatology. We use off-label, but it's not FDA approved. Among this, I think only micafungin is approved for use in the NICU in the European country. And the last point, that is the PICC line removal. It's simply removal, not the replacement. So in the presence of fungal sepsis, you have to remove the PICC as soon as possible.
Thank you, Dr. Habib, for your nice summarization of the cases. Okay, now there are 4 questions for, I think, Dr. Sulagna. Dr. Khya Goshuttam asked whether sending daily blood for cultures through recommenders is not very practical. So do you send the blood culture daily?
Yes, madam. In our unit, whenever any baby is Candida positive, at least for first 72 hours, we send 1 ml of blood culture daily, because in our setup, we have our own backtech machine and our own lab gives the result. So in our setup, it is feasible, but the setups where the blood culture has to be sent to microbiology, there it will be cumbersome.
One question is that
Yes.
this is that we learned that even in we get the fungal blood culture positive fungus infection, we do second and third culture because we confirm that this is this is fungal septicemia or
Blood contamination. Yes.
contamination, blood contamination. You should send 3 blood culture for repeated 3 consecutive blood culture. Every year is a blood culture facility is available. You should send it.
Okay. Thank you.
If there is any fungal candidemia in blood culture, never consider it a contamination. Start antifungal and do whatever you want to do next. For every day of candidemia, the baby will get even worse.
Yes,
So
the incidence of survival will be low. Yeah. Okay, there is another question for, I think, Dr. Agruni Panda. Drug of choice in severe PPHN associated CDH. It's maybe taken by experts also. You can answer any of the experts. What will the drug of choice in PPHN associated congenital diaphragmatic hernia?
There is no drug of choice, but we think that iron or not responds properly, but we titrate and combine these drugs or the Mylinone or inhale prostacyclin, PGI2 inhalation. That's maybe, but no, there is no better drug or base drug for this cases, but we titrate.
Okay, thank you. There's no name, actually. Anonymous attendee has asked the role of magnesium sulfate in neonatal PPHN.
I think can I take this?
Yes, yes, sure.
So magnesium sulfate has been quite a used practice. I would say about 15, 20 years ago, probably. And it was given over 5 days. I think isolated magnesium sulfate, there was some studies in the past which showed some element of vasodilatation in the pulmonary vasculature. But the main risk with that is hypotension. And if you are having systemic hypertension, your PPHN will get worse. So ideally, I think magnesium sulfate has gone out of use now. As pointed out by the other experts, I think it's a combination. I think oxygen and nitric oxide, if you have availability, that's probably the best to start with. And then you can mix and match. There is no ideal drug, to be honest. You have to mix and match various like milrinone and sildenafil. CDH, there have been some studies, like I know CDH is one of the difficult ones to treat for pulmonary hypertension. But I think there are some isolated studies of combination of milrinone and sildenafil, which has given some promising results. I think the study was in Norway recently. So a combination of milrinone and sildenafil have been shown, have shown some good results in CDH.
Okay, Shulagna, you stop sharing.
Okay, ma'am.
Okay, now a few comments I would like to hear from Dr. Vivan, if possible, and then Dr. Shapun.
I think it was, I think I joined in the middle of the PPH, and so I didn't hear the first part, but I think neonatology has advanced a lot actually, because I think I've left the country now about 15 years, and I can see the amount of neonatal interest or the neonatal stuff that people are putting in. I know there is infection is one of the most challenging factors in neonatology in India, and it will probably be one of the most challenging factors. And the weird and wonderful cases that you present is very, very. I mean, I was very much engrossed in this fungal sepsis actually, because we don't get it a lot, to be honest with you. And our experience with sepsis is much less than our Indian colleague counterparts. So I think fungal sepsis, as we know, it's probably one of the most difficult ones to treat, and probably it has got far-reaching effects, because I was planning to ask the question that how long did you treat the endocarditis for? And then I found out that unfortunately the baby succumbed, so I didn't really have an answer to that. But I think it is one of the most difficult things to treat, and I think, to be honest, there is no, I think, proper antibiotic stewardship. If there is one take-home message from here for all neonatologists, and I think the thing should be very clear to wherever the person is practicing neonatology. I think antibiotic stewardship, unless we can narrow down these antibiotics and justify our reasons to give antibiotics, it will be very, very hard to whatever we might try, we might do endless number of studies, but ultimately results will show that unless we can do a proper antibiotic stewardship, these cases and these difficult cases will emerge, and ultimately will take our fertility toll very high. I mean, I know we are trying to achieve a big neonatal mortality target of less than 5%, if I'm not wrong, over the next few years. But unless, I think the message has to be very clear to the peripheries that antibiotic stewardship is probably the most important thing. You don't have to be very, very, very intelligent and clever to do neonatology, but unless you can choose your antibiotic, unless you can use judicious antibiotics, you will end up in trouble.
Thank you, Dr.
Kalpanati, can I ask a question to Bivan?
Yes. Now your turn, and Dr. Shapun.
Bivan, can I practice in Manchester?
I think we still practice. I think over the last 15 years I've been in UK, we are still, first line is still penicillin and gentamicin, and it hasn't changed.
That's great. That's great. Thank you, Dr. Vivan, for enlightening us about this. And any comment from Dr. Shapun?
It was fantastic cases by
and
both
wonderful
of the
presentations.
Agrani and Shulagna. I had some doubt, still I learn every day from the presenters and the experts. So Dr. Khya Bhoshuttam is there. When we were in Institute of Child Health, I have seen in the one of the sensitivity reaction you have shown, voriconazole was sensitive. So, Kia, if you remember, we have
Dr.
tried
Khea,
this
can you have some
voriconazole,
comments after Dr. Shapun?
IV voriconazole, and probably we could save that baby. So, Kia, can you unmute?
Dr.
Khea?
Khea?
Yeah, oh, thank you
Yes,
so much. So it was excellent cases. So,
Yeah.
and when I saw its neonatology, I was when I left all my
Attracted.
job and I'm joined. So very nice cases. Yes, our Shapondar to mone ache. So we have used IV voriconazole and we could save, but fortunately we didn't had end organ involvement in that baby. So sometimes
Yes.
having infective endocarditis is a real tough situations. And I think they didn't had any other option than to do this. And we have some experience of using this caspofungin and micafungin, though these are off-label use. But by this, we have saved a lot of babies. But the problem with us is only that we cannot send daily blood because we have to send it to microbiology department. So I was just asking the expert, is there any alternative recommendation you can send alternate day or something like that? Do you have any idea? I don't have any idea. I just want to learn.
The recommendation is the recommendation.
Yeah.
Yeah.
The alternative.
We have to compromise in our setup, but
That's
that
true.
cannot be propagated as the art of practice. So thank you, Kia, for attending the seminar, because I saw you were posting something, so I requested
And
Somnatha to
Thank
be
you.
the
Thank you so
panelist.
much. Thank you.
The panelist, and the thing is that we are on the end of the program. So as Dr. Atanu Bhadra has told, we have to go for another 1 or 2 series on neonatology. This is very interesting, and I think we will all be enlightened by this. So
you'll be surprised to know why I chosen the neonatology this week, because everyone is busy on a pedestal. So I thought if I'll take another, only the neonatologists, they didn't attend the pedestal. So I think they'll be free. And we are also coming back from that also. So I think it is one of the successful Sandhya Pathshala what we had for the last 9 months. Because it's still 2 minutes past 10 and we are still on discussion. So wonderful.
Just to add, this Sandhya Pathshala is a very popular thing. We are enjoying. I have seen many before,
Yes.
but maybe not full 2 hours. It's a very good initiative by West Bengal.
Even out of the state, they are also many
Absolutely.
doctors attending this.
many.
So any last
So-
comment from the experts? Do you want to say something, Dr. Ratan and Dr. Dinesh? We have learned a lot from you people.
No, madam. Thank you, Bjorn. So,
Okay, thank you. Any word from Dr. Ratan?
Well, presentation of Agroni was fine. And Sulagna, I know Sulagna from very first day of her years. Presidentship here. Sulagna is also a very fine presenter. Nothing more.
Dr. Atanu, last comment to finish. Now today, I think you give the vote of thanks.
I would just,
in spite of
I
me.
would just request everyone to become members of IAP and
Yes.
let us be enriched with all your contributions so that we can do some serious academic work, because West Bengal is lagging behind all the other states, but we have plenty of talent, and I think with everyone's contribution we can go ahead.
Okay, thank you, Dr. Atanu. And it's a wonderful session. Thank you, Agroni. Thank you, Sulagna. You have done 100% justice to your cases. And I must thank the experts also. They have done very nicely, discussed the cases. I thank the Dr. Vivan who has joined from so far away. I'm really happy. I must thank Dr. Atanu, Dr. Shapun, and all the mentors. So the young mentors, Dr. Habib, Dr. Meenakshi, and the delegates who are there and listening the session and made this session successful. And the end without Somnath. He said, I'm busy in Pedista. I said, no, please today make it successful because he is busy in Pedista from morning to night. I think he is still there only. So thank you, Somnath, for running this Zoom without flaw.
Thank you, Didi. Thank you, Didi. আমি
রাজভবন
কলকাতা থেকে অন্তত কত 100 কিলোমিটার তো হবেই।
হ্যাঁ 2 ঘন্টা
কতটা
লাগছে
দূরে গেছি, সেখান থেকে যে করতে পেরেছি, এটাই আমার কাছে মানে আপনাদের ব্লেসিংস, আমি করতে পেরেছি।
যেরকম বৃষ্টি হচ্ছিল চাপ ছিল আজকে।
না না, আমার এখানে তো বৃষ্টি হচ্ছে না। আমি
না
তো
হচ্ছিল, আমি আসার পথে পেয়েছি।
হ্যাঁ, একটু বৃষ্টি হয়েছে। রাইট।
So thank you.
আমি রাজ্যপালের পাশে দেখলাম, গভর্নরের পাশে দেখলাম একটু।
কাকে দেখলে?
সোমনাথ দাকে।
হ্যাঁ, ও তো ব্যান্ড বাজা, ওই ধুতি গেঞ্জি পরিয়ে দুর্গাপুজোর বাজনা বাজিয়ে রাজ্যপালকে আনিয়েছে।
Anyway, chalo, good night.
Okay, thank you and good night to all. And again, we'll meet in the next month, the last Sunday, 8 to 10 p.m. Thank you.
Thank you, ma'am.